I just understand that term likely, because I understand from a legal standpoint that's greater than 51%. But
greater than 50%.
Okay, excuse me, greater than 50%. I mean, there are relatively few things in obstetrics that there's greater than 50% likelihood of having an outcome based on that. I mean, if that's the goal, is to find things that are greater than 50%, it's going to be difficult to find that. And I can't imagine that you would consider it safe that something that's happening 49% of the time is acceptable, but 51% isn't. And I mean, I understand the law, and I understand you have to draw lines, but the 50% numbers is certainly not something that would ever be used in a patient safety discussion in a medical context. Do you understand what I'm saying? And so, you know, if it's something that has to have occurred 51% or more of the time, it's going to be difficult to find almost anything that in obstetrics that occurs with that frequency that anybody that would be saying would take that chance. And then, the semantics are, of course, also important. Of significant pelvic or uterine abnormalities, and then you can debate what the word significant means, and whether that's 1 fibroid or 5 fibroids, or a fibroid is 5 centimeters, a fibroid is 15 centimeters, and what is significant. And I'm sure you don't want to have those sort of semantic discussions, but obviously the semantics are rather important in legal documents.
Well, and there are going to be times where the regulation is not going to require the licensed midwife to send the client for a physician consult, but the midwifery standard of care, the community standard of care, may dictate this is not a proper person for you to continue with for a planned home birth. And this is just that the regulations where it's required for the midwife to send this patient for a physician consult. And it's for, you know, a pre-existing maternal disease or condition likely to affect this current pregnancy. So it may not be something that she is faced with right now, a danger that's existing in this current pregnancy. So I would imagine that this list is going to be shorter than the list of significant disease arising from the pregnancy. And likely, you know, Bonilla could have picked a whole number of other words to put in there, but she picked likely. And that does, we have to give that weight. And so there may be things that you want on there because if, in fact, the risk that everyone is afraid of materializes, it's tragic. But if that risk is there only 20% of the time, it could be that it doesn't belong on this list, but the midwife in his or her practice, 20% is too great of a risk to take on and makes the referral anyway, or says you're not an appropriate client for me. But we have to be able to justify everything on that list to the Office of Administrative Law. And so it has to be something that's likely to impact the pregnancy.
And, you know, again, I agree with you. I don't think midwives are sitting around thinking that 49% is an acceptable risk, nor is 20% of a bad outcome an acceptable risk to us. We are not trying to take on clients who are bad, who have a high risk of a complication during pregnancy. However, again, we have to come back to the question of what is the benefit of the consultation. If it's simply that someone needs to give this woman a thorough, informed consent of the significance of her history, then in many cases we are the best licensed healthcare professionals to do that thoroughly in the context of an hour-long visit and ongoing continuity of care for this woman in the context of individualized care. question is this something that's going to need ongoing monitoring during pregnancy or treatment during pregnancy that cannot be managed within the scope of practice of a licensed midwife? Many of these things do present real risks, whether the risk is 1%, 3%, 5% of recurrence. However, appropriate midwifery care would include the same types of screening and surveillance for a recurrence of the problem that obstetric care would include, and appropriate referral if signs of a current complication arise. There's no reason to believe for many of these things that referral to an obstetrician would inherently convey an increase in improvement in outcomes.
So it looks like from discussions that there was an agreement with that there should be a referral made for a significant pelvic or uterine abnormality, including tumors or malformations. That, you know, that's something that's, you know, that's in existence, and
it probably still doesn't have anything close to a 50% risk, but in the spirit of this, then yeah, we did it. We agreed with it.
Okay. The next one is history of uterine surgery, including but not limited to myomectomy, hysterotomy, or cesarean section. And we've been addressing C-section, so I think that's going to have to be stricken in its current form. What about on those other items? Any update?
On number 2?
Yeah.
You mean the myomectomy or hysterotomy?
Is did any discussion include those items, or was it focused on the C-section?
No, there was no discussion on those items.
All right. 3 is current or significant history of cardiovascular disease, renal disease, hepatic disorders, neurological disorders, severe GI disease.
Oh, I think anytime we get into significant history, maybe it occurred when she was 10, maybe it occurred when she was 15, now she's 30 having a baby, and it's not likely to, how do we weigh the likely to affect this pregnancy and significant history weighed in the past? And so current, there's a lot of things on here. I agree with totally. I never take people who have current histories of all these things, but history in the past, it really depends on how much it's likely to affect the current pregnancy. And I don't want bad outcomes in our practice. I don't want these women to suffer. I want them to have the best care possible, whether I can give it or somebody else can give it. If somebody else can give it better, I send her there. But the significant history part could be struck and kept the rest on number 3, 4, 5, and 6 pretty easily for me.
I think number 6,
7, I don't want epileptic
history.
in my practice.
Tosi. Number 6, current or history of pulmonary embolism or deep vein thrombosis should stay as it is.
Yeah, I think
Well, pulmonary disease could be.
No, number 6.
Oh, sorry. I'm sorry.
Okay, can I
yeah,
interrupt
6,
for 1 second?
absolutely.
In order for us to be able to get through all of these items and make sure that we're able to take notes and make sure we're getting everyone's feedback, if we can go per line item and discuss it one at a time and not jump around. That's what happened at the last meeting, and we didn't really get too far. So if we can go back to number 3 and get the comments on that before we move forward. Okay.
Can I suggest that when you talk about, use the word significant history, that would have to do with current time? Is it something that happened way back when that is now still an issue, as opposed to that it just happened ever?
I question whether significant history is in the opinion of the provider. if it's a history when they were 2 years old of a seizure, and they're 30 years old and have never had a seizure, that's not a significant history. So I think that there's some room for your professional assessment. So I think that it's okay to leave it there.
So you're saying it's up to the discretion of the midwife whether it was significant or not?
Yes.
Would it be different if it said clinically significant? Is that not?
Hi, my name's Yantran, and I'm also here from ACON. I think it is important to keep the significant history part of number 3, especially as well as some of the other ones, just because a significant history of it does not mean that it is resolved. And if it is not current, does not mean that it cannot become an issue during the pregnancy. For instance, a patient might have a history of a heart repair when she was 2, but she may need some further workup during this pregnancy by a physician, even though it was a history of it and is not a current issue. It may become a current issue given the physiologic stresses of the pregnancy.
I think what we're saying as midwives is that we have the ability to triage that and determine whether the insignificant heart murmur that resolved at age 2 needs a referral versus a woman that had transposition of the great vessels and had that repaired as an infant. I think we have the intelligence and the training to discern the difference between those.
I mean,
So you
this is
support
really,
leaving it, Gary? Leaving it with significant.
If we're in agreement that significant history is up to the discretion of the midwife as to whether or not it was significant, yeah. If we're not in agreement on that, I think significant history should be stricken.
Well, it doesn't say any history.
Right.
Pushing because what we say here today, when this is finally enacted as a regulation, makes a difference if somebody has charges against them on the significant history point. Be able to come back to the transcript of this meeting and know how it was discussed.
just to address the litigation issue that someone brought up before. I mean, clearly, significant, you'll get an expert on either side. They'll say it was significant or not significant. And obviously, it's a loaded term and can be defined differently by different people. And, then it's up to the experts when it comes to litigation. But, it's just impossible to write down a list of everything that is normal and to dissect each of these into what is significant or not. I mean, we wouldn't get through number 3 by the end of tomorrow.
That's why the legislature left it up to us. The regulations that they didn't put all the limits on themselves.
I mean, the bottom line is we're comfortable with the way it's worded now, but recognizing the ambiguity of the term.
Right, and that's going to be there, and I think I've explained before that if there is a complaint filed, there is a midwifery consultant who does an initial review to determine whether there was a breach of the standard of care. And so it will be midwifery peers that are looking at this to determine whether the decisions in the case made sense. So there is some flexibility with the terms that are used unless further definition is placed on them. And right now, that's not included in the language of the proposed regulations. So any further discussion about leaving number 3 as is? All right, number 4. Current or significant history of endocrine disorders excluding controlled mild hypothyroidism if severe or symptomatic on medications. I have a proposed okay on this. That is fine as it is.
I'm sorry, fine as it is written in this document? Or
In the chart.
they added this, there's something added here at the end.
Right, we added that together.
Well, no, I wouldn't rely on that.
So I think the way it's written is number 4 on the original document would be agreeable.
So it looks like there were some discussions that it was proposed to add if severe or symptomatic on medications. And did ACOG agree to that change in phone discussions?
I might be able to solve that because if you look at the two, that's on number 4
Uh-huh.
on the chart and on number 5 on the page of regulations. So it's almost like it got tacked onto the wrong
Okay.
place on one or the other.
That looks like a typing error, yeah.
Okay, all right, so I'm tracking. Thank you.
I see.
So yeah, it doesn't sound like there's any concerns about 4.
Okay,
Pardon me. So a severe hypothyroidism that is controlled with medication, would that be required to see physician consult?
What looks like mild is left undefined. Controlled mild.
and again, with each of these, there is gonna be some midwifery decision-making involved.
I would suggest on the mild hypothyroidism, that mild is really a term that doesn't need to be there. If it's controlled, it's controlled. If it's not, it's not. I mean, I'm not really sure what mild hypothyroidism is, actually.
Well, there's some monitoring.
Right, that we could do. Yeah.
I don't know whether mild needs to be there.
Okay.
For clarity,
Can you,
Cardi,
is that fine?
Cardi Seymour Brown, Southern California. For clarity, can you, if they're seeing an endocrinologist who is advising them and managing their medication, are you asking that they see a consultation with an OBGYN as well? Or is it out of place that they're already under the care of an endocrinologist who is monitoring the medication and changes in the pregnancy?
under the code, they would have to see an OBGYN
In
if it's
addition
on
to their
this list. Yeah.
endocrinologist? Okay.
Who would refer them to the endocrinologist?
I mean, actually, I think it's the OBGYN, family physician, or maternal fetal medicine specialist, just to clarify that. I think it's all 3 of those groups. Anyone who's practicing, a physician who's practicing obstetrics. It includes 3 different.
Yeah, trained in obstetrics and gynecology.
So how does that benefit the patient to be seeing 2 physicians when one is really their primary care for this illness, disease, condition? How is the OB gonna?
The legislature didn't really take that into account.
So, I'm a maternal fetal medicine specialist, so I deal with a lot of these high-risk pregnancies. So, a lot of, even if she is seeing an endocrinologist, endocrinologists are not routinely trained in how medical conditions can affect pregnancy and vice versa. So they are good at controlling hypothyroidism or diabetes, but they're not well versed in its effect on pregnancy and pregnancy's effect on the disease.
I feel like it's a lot more, I mean, I'm not sure why hypothyroidism was chosen as opposed to well-controlled diabetes or some other, I mean, I'm not sure why you're again, dicing one disease out of the endocrine disorders.
So can we strike it off the list entirely? Is that?
Yeah, let's do that.
We should strike it off the list entirely?
Or if it
What,
were
strike what?
control
Well,
with
it's
the
just that hypothyroidism is so common, and we see a fair number of clients with controlled hypothyroidism that does not present a problem in their pregnancy, and so I'd rather have it individually listed there as it's probably the most common endocrine disorder that I'm likely to come across. I want it clear that if her numbers are good, she doesn't need extra consultation.
And I'm gonna still raise the point, is it a significant history? You have to make that determination.
But it says
And-
Current or?
True.
And many women are seeing different care providers for that condition already. They can see a naturopath, they can see a physician, they can see a family practice doctor to control that. And so adding, or maybe even excluding that term mild, and just excluding controlled hypothyroidism might be beneficial to women.
Okay. Yes.
Because I think things like Hashimoto's are contained in another one of these issues. I'm not coming up with the right number on this page at the moment, but I think Hashimoto's goes beyond hypothyroidism. Hypothyroidism is a result of Hashimoto's, but it's a different animal.
I just don't hear much difference between mild controlled and controlled. So if we had agreement, maybe we can just stick with agreement.
Yeah.
Because we're not.
Excluding
Why I said
controlled
the opposite.
hypothyroidism.
Well, that's totally fine. I was saying the opposite just so we could move along, but I mean, do you have a preference? Like, does it matter? Does the word mild really contribute much to you?
I don't think it makes any difference to me. I mean, you've still got the significant there, that whether you can argue significant and mild, but so taking mild out, you still got significant, so
Right.
it's fine.
All right, number 5. Current or significant history of pulmonary disease, active tuberculosis, or asthma, if severe or symptomatic, on medication.
I think, doesn't that last portion of severe or symptomatic on medication refer to asthma?
Yes.
I think we need to make it clear that it just refers to asthma, and doesn't refer to the pulmonary disease or active TB.
Yeah, I agree.
It only modifies asthma.
I guess you can just put if severe symptomatic asthma on medication.
Okay. I'm writing, I'm going to tell you my proposal.